Questions so far? All right, let's talk about renal failure. Now, there's really three types of renal failure. Really, there's two types, but they can lead to the final one. We could have acute renal failure, ARF. There could be chronic renal failure, CRF. And these can lead to what we call end-stage renal failure. Now, why we make a big stinker about this? Because it is the 9th killer in America. As I always told you, make sure you know, back and forth, in and out, the 10 killers in America. I guarantee 125%, maybe 150%, they will appear on NCLEX, they will appear on all board stuff. These are the people coming into the hospitals and doctor's offices. So they want to make sure that you're exposed to everything about this. So it's end-stage renal failure. So how do you get this? Okay. Remember how we talked about in terms of jaundice, you could have prehepatic, intrahepatic, and posthepatic. Well, the same way here in renal failure. It could be pre-renal, it could be intrinsic renal, or it could be post-renal. So let me just show you the picture over here, and I'll come back to this. So here's our kidney. Anything going towards the kidney, so you're going to have blood supply going to it. That can cause renal failure. So we're talking about the renal artery, all right, or the afferent arteriole, something going into here, okay? Or it could be during the kidney itself. Intrinsic stuff, that's the stuff I still got to do with you guys. Glomerular diseases, the tubular necrosis, everything that's going to be destroying this picture here can cause renal failure. Or post-renal could be a blockage, so the urine's already made, but now there's problems over here. Whether there's a stone here, whether there's cancer that's being pressed against it, whether there's cancer from the urinary bladder, and you can't move the urine this way. Like I said, I think the biggest theme about pathophysiology is flow. If there's something wrong with the flow, you could guess about all the signs and symptoms. Okay? So again, when I go back to this, you could have a pre-renal, so you have a decreased renal blood flow through the artery, renal artery. Intrinsic renal, so it could be diseases of the nephron itself, glomerulus. Or it could be post-renal, so we have a mechanical blockage of urine, a kidney stone, or cancer, urinary cancer. Okay? So these can all cause that. Okay? So blood tests that we can do. Okay, so we have blood urea nitrogen. This measures the urea blood level. Urea is a byproduct of breaking down proteins. All right, now we don't want this in our blood, so our kidneys are going to take the urea and put it out in our urine. So, if you can't put it out, so think of this. If you're going to have urea come in here, now let's say this is diseased, okay, for whatever reason. If we're going to have urea come in here, but now it can't get through here, for some reason the GFR is decreased, you're not going to be able to get the urea or uric acid in here. So it's going to stay in the capillaries here, and it's going to go out in the efferent arteriole, and it's going to stay in your bloodstream. Does that make sense? So if we have a diseased kidney here, you're going to decrease the GFR. All right? Don't look at this picture in terms of like what I wrote here, but if you have a diseased kidney someplace in here, you're not going to be able to get fluid into there. The GFR is going to decrease, which means that all the toxins are going to stay in your bloodstream. Can't get into it. Does that make sense? So if the BUN increases, or here, if the GFR decreases, then your urea will increase. Is that clear? And similarly, we have another one that's more specific, creatinine. Same thing, all right, but it's a byproduct of muscle metabolism. And what happens here is the same thing. We don't want it in our body. It should go out in your urine. So if there's a decrease of GFR over here, you can't get creatinine into the nephron. So therefore, it's going to stay in here. So again, If your GFR decreases, then your creatinine in your blood is going to increase. So it's a direct relation to GFR. So renal failure means that you're going to have a decrease in GFR, which means that your BUN and creatinine go up. So if you need to see renal function on a person's blood test, check the BUN and creatinine. They're the renal function tests on there. Okay, does that make sense? All right. As well as the liver, the kidney is a very resilient organ. You don't get any symptoms until you lose 80% of the function of the kidney. That's pretty darn well. But that means when you start getting symptoms, it's already a late stage. You only have 20% left. So if you have renal failure and there's no symptoms, but yet your lab results are abnormal, your creatinine and your BUN are increased, but you have no symptoms, we say that you're azotemia, all right? And that's what happens. But you could also have uremia, where you're going to have renal failure and lab abnormalities, but you are going to have symptoms, then you're uremic. And the symptoms could be hypertension, anemia, edema, oliguria, and so forth. We'll get into those. When you have excessive amounts of urea and it gets converted to ammonia, when that ammonia goes inside the brain, it starts affecting the brain. All right? You start having seizures, you get very lethargic, you go into a coma. Really, this is a very peaceful way to go. If I was going to go, I know it sounds bad, I'm talking about death, but this is kind of Kevorkian way. This is a peaceful way to go. And you know, sometimes when you're dealing with hospice and the family there, and they're on dialysis, or let's say they stop doing dialysis, explain to the family that she's not in pain. This is a very peaceful way to go. Does that make sense? You know, because a lot of these might be working with hospice patients, and they're not in pain. This is very peaceful. Does that make sense? Right? So that's what's going on with this. All right. All right. Keep in mind too, a lot of medications will get metabolized and excreted either by the liver or the kidney. Okay? If the liver gets involved, chances are it goes out your poop. If the kidneys are getting involved, then it goes out your urine. So why is this important? When you take pharmacology, you need to know which medications are excreted by the liver and which ones get excreted by the kidney. Because if you have liver failure, you will not use a medication that gets excreted by the liver, because they're going to build up that medication in their body. Same thing with kidney failure. If they have kidney failure, then don't give them medication that gets excreted by the kidney. So when you learn about all your pharmacology, all those drugs, make sure you understand how they get excreted. That's why it's important. And what if they have liver and kidney disease? Well, I don't say you're screwed, but you're very limited to what medications you can give. Does that make sense? And let the doctors figure out what's going on. But you have some knowledge about that. So acute renal failure. Presentation is very sudden onset. It's a rare condition that this would happen, but it's a sudden onset, usually due to severe blood loss, severe infection, trauma. There's also something called acute tubular necrosis. It's a sudden destruction of all the nephrons. And we'll talk about that later on. All right? But that's what happens, ATN. Symptoms of this: anorexic, you get nausea, vomiting, seizures, coma. The fluids and electrolytes imbalances over it. That's usually one of the most challenging things to deal with, because the kidneys are not working right, and the hydrogen's going up and the potassium's going up, so we've got to get something. Now it's too low, too high. It's a nightmare to try and fix. These people tend to be in the intensive care unit because you really need to have one nurse take care of this patient and see what's going on with all those. Okay? The treatment is really to treat the underlying cause, and usually they have to go on dialysis. All right? Chronic renal failure presentation is a gradual onset because you usually have a long-standing disease that's causing this, years before this happens. So we're talking about people with diabetes, high blood pressure, lupus, polycystic kidney disease, all right, and any of the glomerular diseases that we're going to talk about. Now, there's usually 4 stages of this. The first stage is not much of a thing, except that it's called diminished renal reserve, and you lose about 50% of the glomerular filtration rate, the GFR. Other than that, the creatinine level is normal, all right? The next phase is renal insufficiency, and at this point, you now got about 20 to 50% of the GFR that went down, all right? So now you're down to 20 to 50%. If it's about 20, then you're going to have symptoms. If it's between 20 and 50, then you usually won't have symptoms. But one of the symptoms that you would get, if it's around 20, is anemia. Why would you be anemic if you have kidney disease, renal failure? You know this. What's that? Yeah. Kudos to you. Right. Remember, one of the hormones that comes out of the kidney is erythropoietin. Erythropoietin is going to increase red blood cell synthesis. So now if you have renal failure, you're not going to make erythropoietin, which means you're not going to make red blood cells, which means you're going to be anemic. Does that make sense? Right? It's all put together there. Be high blood pressure, polyuria, because you're unable to concentrate stuff. All right? So you end up pouring out more urine at this point. Then you get this chronic renal failure, and at this point, you're now down to the GFR less than 20%. And now you're really going to get a lot more symptoms and signs. You get edema, you get metabolic acidosis because too much hydrogen is going into the bloodstream. You're going to get too much potassium going in there, and that's what we're really concerned about is this potassium. You're also these other ones here, acidosis. But remember, this is probably one of the more serious ones because this will cause a heart attack, right, with the hyperkalemia. But then eventually it'll go to end-stage renal failure, and this is when the GFR is less than 5%. You're not really peeing much out, not much urine's coming out. This is when the kidney just burns out. It just can't do much. At this point, you got to put them on dialysis, okay? So symptoms of this, signs and symptoms. Now, I would like to explain each one of them, and some of them I can, but some of them are just over the scope of this course. So you just have to memorize those things. But some of them you could handle, like you said, like I told you about why would they be anemic, right? You put this together. So fluids and electrolyte imbalances, that makes sense of what's happening over here. And again, this is always the most challenging thing to deal with people with this happening. And usually you get edema, their potassium goes up, sodium goes down, the hydrogens go up, which makes sense why that they would be metabolic acidotic, okay? They usually will have a decrease of vitamin D activation. Remember, you need 3 organs to activate vitamin D. You need your skin from the sunlight going into your skin, you need your liver to go through an intermediate, and also the kidney. So if the kidney can't get involved because you have this renal failure, you're not going to make vitamin D. If you don't make vitamin D, then you're not going to be able to absorb calcium from your diet. So now you have a decrease of calcium. So what does that do? It makes your PTH go out, your parathyroid hormone come out. Now the parathyroid hormone doesn't know where else to get it. It's not coming from your diet, so it's going to have to go to your stores, which is your bone. It's going to increase osteoclastic activity and start making them munch onto your bones, put the calcium into your bloodstream, which means that will lead to osteoporosis. See, step by step by step. Does that make sense with that? Right? Okay? If you decrease the renal function, you're not going to make erythropoietin, which means you're going to have anemia. That makes sense. Okay? You'll increase urea, the ammonia, basically that's converted to ammonia, goes in your brain, it causes seizures, encephalitis, coma, and so forth. They're just poisons that go inside your brain. All right? Hypertension can lead to heart failure. And then you get these other things, nausea, vomiting, GI bleeding, dermatitis, pruritus. It's way over, like I said, it's way over the scope to explain where all these come from. But understand that you don't want to have renal failure. Not a good thing. Too many things happen. Okay? So how do you treat it? Whatever the cause is, we got to treat that. The underlying cause, try and correct the fluids and electrolytes. Whatever you can do with that, add erythropoietin into the regimen. Usually dialysis, and if it's possible, do a kidney transplant or something like this. Okay? End-stage renal failure, okay? Now, some people call it end-stage renal disease, same thing. And what happens here is that this is when we lose about 95% of the kidney. There's nothing more we can do with this. They have to go on dialysis, okay? At this point, it's irreversible. Just put a new kidney in them if that's possible, okay? Usually caused by acute or chronic renal failure. And like I said, dialysis, if they can do a renal transplant, sometimes I don't know if they're candidates or not, okay? And just dialysis, really quick about this thing. There's two types, all right? Dialysis is, we got to basically put a kidney, since your kidneys are not working, then we're going to have a kidney outside your body and being able to work as a kidney. So we have two types. Hemodialysis and something called continuous ambulatory, so walking, peritoneal dialysis. Okay, and I'll talk about that. So hemodialysis is basically you're putting a shunt in the arm and connecting it from a vein to an artery. So let me just show you on the next picture. It'll make more sense. This really doesn't show. This is a hand over here, believe it or not. And what's happening here is that you're going to have the blood from an artery go outside the body, go into this machine that's going to act like a kidney and filter out to make sure that we can get the right combinations and put back into the body with all those electrolytes and water. And then now you have all this filtered blood that can go back into the vein of the artery and go this way. And that's basically what it is. I mean, it goes much more into detail, but it's a very simplistic understanding of it. Does that make sense? Now, do you know anybody who goes for dialysis? It used to be really bad. Like, it was supposed to be, if I remember, 8 hours a day for every day of the week. But now it's better.
I work on my dialysis.
So what are they now? So one person goes...
It depends on how much what their capacity is.
Yeah.
But normally 4 hours.
4 hours.
Give or take on how...
3 times a day? Or 3 times a week?
Yeah.
Yeah,
Either
so...
Monday, Wednesday, Friday, or Tuesday.
Yeah, that's what I was saying, like 4 to 5 hours, 3 times a week, something like that. It's gotten better, but they got to do this for the rest of their life. It becomes a routine. And the way it's set up is that, you know, you have the child over here, you can have this at home, all right, but usually it's done in the hospital because the insurance company usually doesn't pay all that. But yeah, you have this shunt where it's going to go in one and out the other, all right, and it's got to do that, like I said, it's 4 hours, about 3 times a week, yeah. It used to be every day 8 hours. That was about 10 years ago, 15 years ago. Then you have this continuous ambulatory peritoneal dialysis, okay? What this does is that they put in, and don't worry about what's in the solution, okay? It's too complicated. I just want you to get an introduction of this. They have this permanent catheter that goes into their belly. And what happens is they're going to put this filtered material into the belly, into the peritoneal cavity. That's why we call it peritoneal dialysis, okay? So they put this in them, and this filtration material, this special solution, is going to do certain things that is able to draw out as osmotic solutions. It's going to be able to draw out and put things back into the blood system. But then eventually all that fluid needs to go out of the body. So you have this bag that it actually will go out. So it allows you, so I thought it, so it's, you're able to walk around and sleep while the dialysis is occurring, but you're saying it's not 4 to 5 times anymore. You just do it 1 time for 8 hours.
Some people.
So you're going to have this permanent tube that goes into the belly, into the peritoneal cavity. So all the solution goes in, stays in there, we'll close this off, and then we're going to add a bag to the waist, and we put the tube now, we open it, and we have all the solution going into the bag. So now it allows them to walk around, go to their job, I wouldn't say play ball, but I mean, doing that kind of thing. So it allows you to ambulate. Okay, so renal stenosis. We did this slide before, hypertension. We talked about the normal and pre-hypertensive and stage 1 hypertension, stage 2 hypertension. So this is a good review for you guys. And we talked about that there's two different types of hypertension. We said that the most common one is something we call essential hypertension, and that's going to make up a lot, like 95% of all hypertension, is that we really have it idiopathic. We don't really have a reason for it. It just happens as we get older. However, there's 5% that we do have a particular reason for, that we do find that there's an identifiable cause for this. And that's only 5%. Now, of this, the non-essential or secondary hypertension, that the most common reason for that is what we call renal stenosis, or renal artery stenosis, the most common cause of non-essential hypertension. And it's usually due to atherosclerosis that occurs in the renal artery. Okay? So what we're looking at over here, it's the major artery that comes out the abdominal aorta, and this is where there's going to be some sort of atherosclerosis happening. All right, just the way we see atherosclerosis happening in, let's say, coronary artery disease, we can now have atherosclerosis that's happening over here. And when you do a angiogram or an MRI showing this, you can see where the stricture is actually happening, the actual stenosis that's going to the right kidney in this case. So how does this occur? All right? How does this actually cause hypertension? So we got to go back to this picture here with our good old friend, the monkey, for you to understand this. So this is what happens. If this is going to be, all right, so this is our afferent arteriole. Okay, so here, its blood is going to go this way. This is going to be, my markers here. This is your afferent arteriole, okay, arteriole, and not artery. And that's what this is over here. And your efferent arteriole, that I can use for both pictures, is over here. This is going to be our renal artery here. So renal artery is that. Okay? Now, normally we have blood flow going through here, but now there's going to be some sort of atherosclerotic plaque that's going to build up here. We have some atherosclerosis over here and over here. So now this has become narrower, right? So we have a stenosis that's going through here. That's why we call it the renal artery stenosis, because it's stenotic. Now, if this becomes stenotic, then what's the blood flow going to be like here, all right? The blood flow going to the kidney is going to decrease or increase if we're going to make this narrower. Good, it's going to decrease blood flow. If you're going to decrease blood flow through here, now normally here's a little guy that's going to collect these bananas that are coming through here. There's going to be less blood flow over here. So what happens if there's less blood flow, then what happens to the blood pressure going into the glomerulus? Does it increase or decrease? Decrease, right? Decrease blood flow to the kidney, decrease blood pressure. If the blood pressure is going to decrease here, then what's going to happen to our GFR? How fast is this going to happen if we're going to lower the blood pressure? It's going to decrease, all right? So if we're going to decrease the GFR, then are these bananas that are coming through here, are they going to move down the PCT, the proximal convoluted tubule, slowly or fast? Slow, okay? So now going like this. It's going to move very slow. It normally will go like this, but now it's going like this. If that happens, is the monkey going to be able to pick up more than this? Now, normally 65% we're allowed to pick in. That's how it works normally, okay? Reabsorption in the PCT, 65%, 2/3 of what comes in here is going to be picked up by the monkey. So if you have 100 bananas in here, he can pick up 65 of them. So now if it moves slower, then how much is he going to reabsorb or pick up? More or less? More. So instead of 65, maybe he's picking up 85, right? So if that happens, we're going to reabsorb more at the PCT. So that means that we're going to have less going into our, so it's less going into the PCT, or at least there's going to be more being reabsorbed up here, so there's going to be less water and electrolytes going into the loop of Henle and the DCT, and that's going to change things. So you'll hear an abdominal bruit, usually due to that, the blood flow going through the narrow passageway of the renal artery, okay? Your blood pressure is going to decrease as the blood flow to the kidney is going to decrease. The blood pressure in the afferent arteriole will decrease also, all right? And when that happens, you're going to actually get renin, because like I said, you have this juxtaglomerular apparatus. This here, which is the DCT, is going to touch the area of the afferent arteriole, this is the juxtaglomerular apparatus, and this is going to sense a decrease in blood pressure here. When it does, it's going to, this area is going to send out or secrete renin. Decrease in blood pressure, renin comes out. And those step-by-step process, you're going to need to, the renin is going to increase blood pressure. So if there's a decrease in blood pressure in afferent arteriole, your GFR, your glomerular filtration rate, will decrease. So that means there's going to be a decrease of volume of the filtrate. Okay? That means the PCT, the monkey, is going to pick up more bananas. So you're going to increase reabsorption in the proximal convoluted tubule. Okay? Which means that there's going to be less sodium and less water and filtrate concentration in the DCT. That's going to be, if more of it's going to get reabsorbed up here, well, there's going to be less of it going to be in the DCT. All right? That's going to, and keep in mind, like I showed you before, the DCT is all mixed together, or mushed together. The DCT is touching here, and the DCT is going to be using chemoreceptors and osmoreceptors and the macula densa of the juxtaglomerular apparatus is going to secrete more paracrines to target G cells, and that's going to release even more renin. So now you have all this renin from low blood pressure that you just picked up over here, and because there's less sodium, there's less concentration that's going to be over here, all of this is going to get compounded and is going to release or make the kidneys secrete more renin. All this renin that's coming out, you're going to have an increase in blood pressure, and this will cause the person to have hypertension, high blood pressure. Okay? So it's step-by-step that's going on over here. If you guys are lost on a sense that we're talking about the juxtaglomerular apparatus, you need to go back. And it's in those first 50 slides or so, and explains all about the juxtaglomerular apparatus, the JGA. You need to know that stuff for you to understand both how caffeine works, how it works normally, and how we're dealing with renal artery stenosis. It's vital for you to know those things. Okay? And also, do you understand why you have a decrease in urine? If you're going to have a lot of reabsorption happening up here, there's going to be less sodium, less water. That means there's going to be less urine that's coming out there, right? So yeah, think about it. You're going to have renal failure, and because of, let's say, the renal stenosis, you're going to have an increase in blood pressure, plus you're going to have a decrease in urine output, all right? Not only that, but if it's going to reabsorb sodium, because the aldosterone is going to be there, water is going to be reabsorbed, and that's going to make less urine. Okay?